Hi, my name is Dermot Kearney. I'm a cardiologist working at the Queen Elizabeth Hospital in Gateshead in the northeast of England, affiliated to the University of Newcastle upon Tyne, and I'm also the current president of the Catholic Medical Association in the United Kingdom. Together we can help medicine thrive. Today we're going to discuss the issue of management of high-risk pregnancy, and particularly emphasising the Catholic approach. The Catholic approach, of course, is based upon the dignity of the human person, the inherent dignity of the human person, and the principle that all human life is sacred and must be cherished, cared for, protected from conception to natural death. I'm afraid that approach is not always found in the secular world. I was at a meeting a number of years ago in London where the topic discussed was management of high-risk pregnancy. And a number of cases were presented, and almost unanimously in the auditorium, in all cases, the only option being put forward to solve the problems, which in some cases were genuine threats to the life of the mother and the child. The only option being put forward was termination, and not to use the word abortion, and use termination or other euphemisms. However, there are some situations that do represent a genuine risk to the mother, and we have to take those into account. However, from the Catholic point of view, attempts should always be made in these difficult situations to save both mother and child. And in the vast majority of cases, that will be possible. There will be some tragic situations where it may not be possible to save both. Keep in mind that if it's a very early stage pregnancy, if the mother dies, the child is also going to die. And that's important to remember that as well. There are two specific obstetric situations I can think of that could pose ethical dilemmas for Catholic doctors and problems in terms of management. The first one, which is very uncommon, by the way, is a serious infection within the womb during pregnancy. So infection involving the fetus, the placenta, the fetal membranes. The initial treatment, of course, will be supportive and resuscitative, appropriate antibiotic therapy. But if despite those measures, there is an ongoing risk or an increasing risk to the life of the mother, it may be necessary in some situations, if the child is still alive, of course, it may be necessary in some cases to deliver the child prematurely. And if it's a very premature fetus, then there isn't any chance of survival. If, however, the pregnancy is advanced towards sort of 20, 21, 22 weeks, it may be possible to attempt to save the child as well as saving the life of the mother. The other sort of similar situation that I can think of from the obstetric point of view would be a serious cancer of the womb, endometrial cancer in the early stages of pregnancy, where it's considered the only option is hysterectomy. Again, if it's close to the stage of viability, 20, 21, 22 weeks, then it should be possible to delay surgical management and attempt to deliver the child and perform hysterectomy at a stage where the child may be viable and may still survive. But if it's very early stages and hysterectomy is necessary, then it may not be possible to save them both. But the important principle here is that every effort is made in all of these cases to save both the mother and the child. I'm quoting from the Dublin Declaration. This was a meeting held in Dublin in September 2012. There were eminent obstetricians, largely pro-life, I would have to say, from around the world gathered together. And their statement at the end of the conference included the definitive statement that we affirm that direct abortion, that is the purposeful destruction of the unborn child, is never medically necessary to save the life of a woman. And that's very important for Catholic doctors and other doctors who want to practice good ethical medicine to keep in mind. Abortion is never necessary to save the life of a woman, despite some potentially dangerous situations. Now, there are other situations, and particularly in my area of practice, that are considered to be possibly or present the highest risk to a woman in pregnancy. They tend to be cardiac or cardiopulmonary, in particular conditions such as moderate or severe pulmonary hypertension, severe heart failure regardless of the etiology, a woman who's had previous episodes of peripartum cardiomyopathy, Marfan syndrome, where there's a risk of acute aortic dissection and severe acute aortic regurgitation. So these are genuine conditions that may pre-exist the woman becoming pregnant, or may only be discovered during the pregnancy, may be aggravated by the pregnancy in some situations. However, as a cardiologist, I am satisfied to state that in none of these situations is it necessary to resort to abortion to save the life of the mother. It's always possible, with very close monitoring, with very good, appropriate care, to allow the pregnancy to advance to a stage of viability, with very close monitoring and being prepared to act to maybe prematurely deliver the child if serious problems arise. But in all situations, you do not need to resort to direct abortion to protect the life of the mother. The aim always should be to save both mother and child. I would draw your attention particularly to two key players in the area of pulmonary hypertension. Now, pulmonary hypertension is usually considered the most dangerous situation for a woman in pregnancy, particularly severe pulmonary hypertension. There are two people. One is called David Kearney from Sheffield in England, who published a very important paper in 2010. It was the first series of successive cases of women who opted to continue their pregnancies despite the diagnosis of severe pulmonary hypertension. And he had 10 successive pregnancies among 9 women between 2002 and 2009, and all of them survived. But the textbooks will tell you in this situation, there's a 40 to 70% mortality rate, and the termination should always be offered. David Kearney's paper showed that with good modern management of pulmonary hypertension, very close monitoring, and good multidisciplinary teamwork, that high mortality rate does not necessarily have to be the case. Even more impressive is a wonderful lady in Milwaukee, Wisconsin, called Diane Zwicky, who's a former nurse, became a doctor, became a cardiologist, and now specializes in the area of pulmonary hypertension, particularly in pregnancy. And last count in 2018, she had 170 consecutive cases of women with mostly moderate or severe pulmonary hypertension, all of whom survived, 186 babies, all of whom survived, with, again, a good modern approach, using all of the skills that she has in the management of pulmonary hypertension, meticulous attention to fluid management, being aware that there are certain times in the pregnancy, and particularly in the peripartum and the postpartum period, where there's an increased risk, and being prepared to deal with any problems that might arise. Good, appropriate care. She got all of those women and their children safely through the pregnancies. It emphasizes for me that the Catholic approach is correct in this area. That we never need to resort to abortion. We never need to resort to deliberately killing another human person to try and save someone else. And I hope you can adhere to that principle throughout your practice. So I wish you every good blessing in your practice. May God bless you. Thank you.